we'll just wait another minute or so. All right, hello everybody. Welcome to Pediatric Grand Rounds. I'm going to turn it over to Dr. Mel Hyman to introduce our speaker for today.
Hi, everybody. It's my pleasure to introduce Dr. Gigi Berriman. Dr. Berriman is currently affiliated with the Pediatric Gastroenterology Department at Children's University Hospital in Brussels, Belgium. She's in Belgium, or actually in southern France right now on vacation, but is professor at Free University Brussels. Received her MD and did pediatric residency at Antwerp University in Belgium, and then did a GI nutrition fellowship with us at UCSF in 1987 and was on our faculty for a couple of years until 1992. So it's a pleasure to welcome her back. She's an active investigator. Her career has focused on feeding disorders, gastric emptying problems, and pediatric inflammatory bowel disease. She's had many national and international publications and positions. She's been a leader in the Belgium, actually president of Belgium Society for Pediatric Gastroenterology, Hepatology, and Nutrition, and was the general secretary of the European Society for Pediatric Gastroenterology, Hepatology, and Nutrition between 2015 and 18. She's edited many society guidelines and published many papers, and we look forward to her talk today on nutrition in Crohn's disease. Gigi, welcome.
Thank you, Mel. Thank you very much for your too kind introduction. I always remember UCSF very fondly. It was my greatest professional experience, and I'm very proud to be an alumnus of UCSF. That was certainly a very determining factor for the rest of my career. Thank you for having invited me. It's really a great honor to speak at UCSF Grand Rounds, which I loved attending so much when I was there. And of course, I would have very much liked to visit and be with you, but this is almost as good. I see you, I see the Golden Gate Bridge. We are very good friends. And so it's just important that we get through these difficult times together. Thank you for the subject, which is very close to my heart. To be able to focus with you all for about an hour on nutrition as a therapeutic strategy for pediatric Crohn's disease. It's been very much in the highlights of the last medical conferences because there have been some important studies that came out. But I would like to review nutrition as a whole regarding therapy for Crohn's. If I can, I'm trying to move the slides forward.
Can you click your mouse?
Yeah.
And then does it let you?
No, not this time.
Try again. I can run the slides and just tell me when to go to the next slide.
Okay, next slide, please. Nutrition is a very constant factor in everybody's life, and now it is key also regarding diseases. Maybe it was always like that. We remember Hippocrates said, your food is your medicine, and let your medicine be your food. Since food and the way we nourish ourselves has changed a lot the last years due to industrialization of food components. And we see that it may be linked to the increasing incidence of inflammatory bowel disease. So that's the focus of our topic today. Next slide. So I'd like to look with you at some background of Crohn's disease, especially the epidemiology, some very brief data on the microbiome, because that's the key for the influence of nutrition on inflammation, and then review the data that are available so far and that are mostly from pediatric studies on using nutrition as an induction therapy for active CD or for maintenance of remission, and what the data are regarding prevention of inflammation, and that will lead us to some conclusions. Next one. Inflammatory bowel disease, as you know, has different clinical presentations and phenotypes, and the diagnosis we use now is based on histology. Regarding the influence of nutrition, it's mostly on what we call Crohn's disease as a whole that we have data. We can distinguish ulcerative colitis, or when it's difficult to specify which type, and that can be a temporary factor, we talk about IBDU or unspecified. And furthermore, there are categories that are depending on the location of the disease in the intestine. Next one. The incidence of pediatric IBD around the world has been increasing. And as Mel also knows very well, when I started as a fellow, pediatric IBD and Crohn's more specifically was quite rare. And it was also considered a rare disease back when I returned in Belgium. It was of course well known by the internists, but during the course of the years, unfortunately, it became more and more of a problem, and it was seen more and more often in our countries, in the US, in Western Europe, in Scandinavian countries, and reports started to increase also in newly industrialized countries, in other continents, such as Africa, Asia, and South America. Next, please. And so when you look at this increasing trend that has been described by several authors and that are really backed by different registry data, the first case of UC was reported back in 1859. There was the Industrial Revolution. And as the Western world evolved, there were increasing reports of IBD-like phenomena. The first case of UC in China was reported 100 years later in 1956, and the incidence is also rising in these newly industrialized countries. Whereas in our countries, in Belgium, usually we say that the incidence is around 6 per 100,000. We may be up to 8 per 100,000 nowadays. Next. So to put it in a very simple way, with globalization, nutritional patterns have changed. And to put it, like a stereotype, we have too much of what you see on the left side, and that is described or known as the Western diet, and too little of the not processed foods such as vegetables and fruits. The next one. We can, to come back about the classification for Crohn's disease, for adults, there is the Montreal classification, and for pediatrics, the Paris classification has been published, where we also take into account growth data, because Crohn's disease affecting developing children can affect their development and their pubertal development, and also the age at which the disease first appears. Next. For all treatment options, we do know that patients have a very individual response. So the response is variable, and that's what's also defining the phenotype of the disease. So the goal would be to evolve towards personalized medicine, where we can use biomarkers to determine which of the now available pharmacological options, but also nutrition, is best for one particular patient. Next. Treat to target concepts have also evolved, whereas initially one would be satisfied with a symptomatic response, and these responses can be measured with scores in pediatrics, the PCDAI, for Crohn's, of the PUCAI, for ulcerative colitis. We are now more demanding, and we like to treat the patient so completely that you can talk about remission, but also biochemical remission and mucosal healing, even transmural healing. It's only from that stage on, when you obtain mucosal healing, that you can consider discontinuing pharmacotherapy. And importantly, enteral nutrition, exclusive enteral nutrition, has shown to lead to mucosal healing. Next. So nutrition, especially in Crohn's disease, should not only be considered as support for patients who have lost weight or who have a growth delay, but also as an adjuvant, or some think or hope also as monotherapy for induction and also for maintenance in Crohn's disease. And you see here a description of the armamentarium, all the different agents that we can use for Crohn's, and fortunately those are increasing now with a very rapid pace with pharmaco development. But we are now looking at the effect that nutrition can have on the disease. Next. IBD pathogenesis is multifactorial. As you know, there are many disease susceptibility genes that have been identified. And of course, depending on populations, that can be affected more by some types of the disease. The phenotype is also variable, but environmental factors, and smoking is one of them, have been identified, and also the presence of some luminal bacteria. And it's especially there that nutrition also comes in, because nutrition does affect luminal bacteria. Next. So just to give you a few data on microbiome, there is some bugs or some microbes are known as being the good microbes, but one healthy gut microbiome does not exist. In Leuven, the RAAS group has worked a lot on identifying a microbiome of healthy people, for instance, the Flemish Gut Flora project. And they have shown that there are several factors that affect a healthy person's microbiome, and that person's microbiome is as specific and personal as is his fingerprint. But the microbiome is subject to different influences, such as demographics, gender, BMI, drugs. The impact of genetics is rather limited, but there is a very substantial effect of the diet. And looking at these different types of microbiome, they came to 3 enterotypes, and these enterotypes are mostly determined by the type of diet. So whether you eat a lot of fruit and vegetables, or bread, or a Western diet will influence your type of microbiome and determine the enterotype you belong to. Next one. And these enterotypes, of course, determine the substrate degradation characteristics of the microbiota. So they have described the P enterotype that has a low lipolytic and proteolytic fermentation capacity, and that is seen in healthy people who take mostly an agrarian diet. The B enterotype has a high saccharolytic and proteolytic capacity, and that's typical for people who use a Western diet. And then a third R enterotype, which also has a high proteolytic and saccharolytic potential, but with a long transit time resulting in hard stools, and where there's a lack of fermentable substrates. Now, next one. It has been seen that the bacteroides, or the B2 enterotype, is associated with inflammation in loose stools. And in adults, it's been shown that Crohn's disease is characterized by this B2 enterotype. This enterotype shows a lower cell count, 50% reduction, and has a lower abundance of healthy genera. And there's a lower diversity. And so we also talk about dysbiosis. So the type of patients do have a specific enterotype. Next one. And the same has been shown recently in children who are diagnosed with Crohn's. Their microbiome, when compared to children of the same age without any type of disease, shows that they have more enterococcus that you see in orange color here, and they have more enterococcus and they have less Clostridia. Next. So this change in microbiome, or this influence of nutrition on microbiome, is probably one of the important explanations of the effect of nutrition on inflammation. And when you see on the left a picture of how a healthy gut shows, with a biofilm, with diverse bacteria and a thick mucus layer, different lymphocytes and regulatory lymphocytes in the lamina propria. In Crohn's disease, this is altered with less diversity. The dysbiosis, the mucus layer disappears, the tight junctions break down, there's loss of some receptors, and also the regular T cells are replaced by inflammatory T cells. Next. There are several studies, and they have been reviewed in a very good paper in Gut by Ariel Levine. The group of Ariel Levine has worked a lot on Crohn's and nutrition. And in this Gut paper, he basically reviews all in vitro and animal studies that show some link between one nutrient and one function of either host or microbiome or microbe. And so looking at all these different elements, all these different studies, the nutrients that come out as being having a bad or deleterious effect are high fat and bile acids, high animal protein, high sugar, emulsifiers, maltodextrins, carrageenans, low fiber, low resistant starch, gluten, alcohol, and taurine. Next one. So now I'd like to review with you the studies that are available so far and that show an effect of nutrition on the induction of remission in children with active Crohn's disease. So first of all, there's the exclusive enteral nutrition, or EEN, that has been used for quite some time, mostly in children, rarely in adults, which also affects the fact that, next slide, in a recent Cochrane review that looked at all the available studies, next one, most of them were pediatrics. There were 27 studies selected, only 3 with a low risk of bias. And the conclusion of this Cochrane review is that the studies that have been done in adults with active CD show that steroids are more effective than EN to obtain clinical remission. In all these studies, some are from quite some time ago, the enteral nutrition was compared to steroids. In children, however, the opposite was shown, and that is that EN was more effective than steroids. And part of the reason is also that with EN, you could obtain mucosal healing, whereas with steroids, that has never been shown. But unfortunately, all these studies are rated as having a very low quality evidence. Importantly, though, protein composition does not influence the effect. This means that some polymeric foods are used, which are, of course, only liquids in a liquid form, but there's no advantage to using amino acid formulas over polymeric. And of course, compliance is difficult because it asks really for quite some motivation to follow an exclusively enteral diet for 6 weeks. Next. These diets are, should supply your entire caloric need. So for an adolescent, you would come up to 2 liters a day. Some are motivated and drink it. Some will have a tube in place, a nasogastric tube, to receive the food, and theoretically they can go to school, but you can imagine that it's easier said than done. Next one. But based on those good results of enteral nutrition, the guidelines for Crohn's disease that were published in 2014 by Espegan and in collaboration with ECHO advised that for a newly diagnosed pediatric patient, you should use exclusive enteral nutrition for 6 weeks if the patient responds, which means if the patient cannot tolerate it, of course, you have no choice but going to prednisone at once. But if the patient tolerates it, then exclusive enteral nutrition is recommended for a period of 6 to 8 weeks. And then maintenance therapy is continued with immunosuppression for the most part. The advantage of this approach is also that it gives you time for doing other things, such as evaluating the patient's vaccination status, administrating live vaccines if they need to. So we really try to follow that advice in Europe now, which of course has the consequence that most patients do start with exclusive enteral nutrition and then switch to immune suppression. Next one. But like we said, it's quite difficult to comply with this exclusive enteral feed. And that's why the group in Edinburgh analyzed the composition and proposes a diet that is a solid diet and that they hypothesized would have the same effect as exclusive enteral nutrition. And they call their diet CDED. Next one. So this treatment of active Crohn's disease with an ordinary food-based diet is a CDED. And what they published, next one, is the use of, if you look at what this 15-year-old boy could eat, is a very palatable diet, but it is lactose-free and gluten-free. But it allows for vegetables, for fruit, it allows for cereals that are gluten-free, it allows for cheeses, rice, fish, so of course much easier to adhere to. Next one. And the study they published showed, on the one hand, a comparison in healthy adults regarding the tolerance for this type of diet compared to exclusive enteral nutrition. And obviously the CDED was much better adhered to. They also looked at inflammation in rats, and they came up with some positive effects for inflammation of the tissues in rats. And then what's of interest to us, they had 5 children with active CD in this prospective case study, and they looked at response and remission after 8 weeks. And they saw of these 5 children that 4 patients responded and 3 were in remission. Of note is that 3 of these patients were on thiopurine and 1 on thiopurine and anti-TNF. So these patients did well, and the numbers for response and remission are quite high, but it was not monotherapy, it was an adjuvant therapy mostly. Next one. So lastly, I think most important study that has been performed these last years, Ari Levine study, that is the Crohn's disease exclusion diet, next one. And that has the merit of being a randomized controlled trial. The idea is that exclusive enteral nutrition was necessary because it was known that if you would not adhere to the diet or to the exclusive diet, that results were bad. You see that exclusive enteral nutrition versus 50% enteral nutrition and a liberal diet on the side resulted in almost insignificant remission rates in the children who had the partial enteral nutrition. So that's why we would always really enhance and the fact that when exclusive nutrition was used, it really did have to be totally exclusive. So now this idea was challenged with a protocol that you see on the next slide. And the next. In this randomized controlled trial, group 2 was treated as we used to do it, so to speak. They had exclusive enteral nutrition for 6 weeks. And this was on the form of Modulen, that is a formula from Nestlé that's used quite a bit in Europe. And then after the 6 weeks, they would go on with a liberalized diet. They would progressively expand their diet as the dietitian told them, but without specific exclusions, and they would still take 25% of enteral nutrition. Whereas in the CDED, which is the Crohn's disease exclusion diet, some foodstuffs were allowed from the start, which is during the week 0 to 6, patients would have 50% of Modulen, and 50% of their calories would come from food, which are allowed in the phase 1 of what they call the Modulife program. Now, this phase 1 is still very restrictive. It is 2 eggs a day or a chicken breast, potatoes that are cooled. So still very restrictive, but allows you to chew and is, of course, more palatable than exclusive Modulen. Then during week 6 to 12, patients go down to 25% of Modulen, and they are allowed foodstuffs from the phase 2 of the CDED diet. And now some more foods are permitted, but still it's gluten-free, of course. And if you're interested, you can find the details of the diet in the paper. Next. So what they showed next, first of all, was that as expected, the tolerance, of course, and this was a primary endpoint, the tolerance was much better for the CDED diet next. But at week 6, remission and response rates were similar for both. Next one. But when after week 6, diet was liberalized in the group of enteral nutrition as we usually did it, remission, or many patients lost remission, and remission at week 12 was only 56% from the patients who were in remission at week 6, as compared to 87.5%, almost 88% in the CDED diet. So there was the significant difference occurred from week 6 to 12 when other foods are again allowed. Next one. There was a study of the microbiome of these patients, and this may explain what happened. As you see in the first column, from week 0 to 6, for both groups, there was a decrease of actinobacteria and of proteobacteria, very similar in both groups, whereas during the period from 6 to 12 weeks, in the CDED diet, the proteobacteria were still decreasing, but there was a major rebound in the patients who were allowed to liberalize their diet as they saw fit. Next one. So these are, I think, the most interesting data. Of course, the CDED is more palatable and can be tolerated by more patients, but it is the re-exposure to the liberal diet, despite remission in the EEN arm, that leads to relapse of inflammation and reduces the number of patients that can sustain the remission. Next one. So if we look at the flow chart of the patients a little more in detail, you see that 40 and 38 patients were randomized. In the group that was taking the exclusive enteral diet, 4 stopped within 48 hours, compliance is less. At the start, there were 3 and 4 patients who also had immune suppression. At week 6, response was similar in both groups. Corticosteroid-free remission was 80% in the CDED group and 73% in the EEN group. And of those patients who were in remission, 28 out of 32 stayed in remission at week 12 in the CDED group, whereas 14 of 25 only half remained in remission in the standard therapy group. But by that time, immune suppression was given to 12 patients in the first group and 11 in the second group. So there's certainly an effect from nutrition, but still these patients, most of the patients needed immune suppression. Next one. So if you look at the evidence, look at the levels of evidence, the CD-Treat, which is a case series, only has a level of evidence of 4. Of course, the randomized controlled trial has a level of evidence of 1. For response, you have 80% and 85. And for remission, you have 60 and 80, but there's no recommendation possible. There's no grade possible based on the studies that are available at this point. Next one. Interestingly, and also recently published, is that it is possible to identify, remember we talked about responders and biomarkers, patients who will achieve remission already respond after 3 weeks. So this makes it possible to avoid burdening patients with nutritional therapy if they're not going to respond. So after 3 weeks, an evaluation is certainly a good idea. Next one. Now, if we can get these patients in remission, if we can get up to 80-85% in remission using this therapy, can we maintain remission? Of course, that's the hopes in the hypothesis, but so far we have no high-level data. We will look at what we have. And then the question also is whether we can prevent disease manifestation using nutrition. Next. Again, the same nutrients as we talked before. Western diet, low in fiber, rich in total fat, animal protein, polyunsaturated fats, and refined sugars will alter microbiota composition and result in dysbiosis, in increased permeability, and cause low-grade inflammation. Next. So you have seen these are the nutrients or the additives that are the target of the different diets that we will now name and that have been recommended. And interestingly, it's also wheat and gluten. Next. So first of all, in the CDED program, that is also called the Modulen program, you see that 0 to 6 weeks is this phase 1 that was used in the Levine study, and then the 7 to 12 weeks for the patients who were in remission, and the phase 2 allows more foods than the phase 1, obviously. The hypothesis is now that these patients who are still in remission could go on with a more liberalized diet, that is the phase 3, with the help of a dietitian, that they would continue to take 25% of their calories as an enteral nutrition supplement, and that they would remain in remission, which is of course very desirable, but this is a hypothesis that is still under study. The results are awaited. Next one. So based on these ideas, different diets have been proposed, the CDED, the CD3 that we discussed. There are cookbooks, tasty and healthy, recipes, Mediterranean diets. The specific carbohydrate diet comes from the US. And more than that, I'll show you a list in the next slide. If we go to the next slide, there's been a publication of the different diets that have been proposed for adults. And you see some that we know from the children, the EEN, the specific carbohydrate diet, also low FODMAP, that you may know better from IBS, IG4 exclusion, low fat, Paleolithic, vegetarian or semi-vegetarian, vegan maker's diet, life without bread, the fit diet, anti-inflammatory diet. Next. And these diets all have some common exclusions and some mandatory or also many allowed foods. You'll notice that the Mediterranean diet is the only one that allows alcohol. The emulsifiers, lactose, gluten in most diets are the ones that are not allowed. Fruits and vegetables, fibers are allowed. It's only in the CDED that you have mandatory foods such as the chicken and the eggs in the phase 1 and the potatoes, apple and bananas. Next one. So if we sum up, foods to be avoided based on these data are all processed and packed foods, animal fats, deep fried food, gluten, wheat, salt, sugar, and honey. And next one, if we want to adhere to those diets, there are still quite a few allowed foods, of course, but it does ask for education and reorganization in how you shop and how you cook. But it's actually quite feasible using vegetables, grains, legumes. Natural plain yogurts is allowed, eggs, oils, fish, seafood, chicken, spices. So it's still a quite livable diet. Next one. For prevention, there's quite a large Swedish prospective cohort of over 83,000 participants that showed that adherence to the Mediterranean diet actually does lower the risk to develop CD later in life. And this was not found for UC. See that the hazard ratio was reduced by half. Next one. So although we don't have any strong evidence that we would eradicate intestinal inflammation or IBD using that type of diet, the United European Gastroenterology Association and the European Society for Pediatric Gastroenterology, Hepatology and Nutrition, so the sister society of NASPGHAN, think it's a good idea to talk to our policymakers at the European Parliament to try to convince them to get more education regarding healthy diets, healthy food, which is of course not only important for inflammatory bowel disease, but for lots of other diseases. So we try to talk to them about labeling, food labeling, obtain equal care for all, of course. And we have started with UEG now with a series of webinars on food and microbiome that are that are supposed to reach a broader public. So that's our task that we consider useful for educating people. But of course, like I said, it will probably have an effect on inflammation, but it's not a treatment yet, unfortunately. It's not the cure for intestinal inflammation. Next one. So in conclusion, I would say that the increased incidence of IBD in our westernized countries may certainly be due, at least in part, to dietary changes. It's quite clear that food influences the intestinal microbiome, and that may be the key and the explanation for this rise in problems with intestinal inflammation. It has been shown, especially in mechanistic studies, that food constituents cause inflammation, but so far clinical studies are limited. I've discussed with you the recent studies that were performed in pediatrics and that certainly do have their merit given how difficult it is to perform clinical studies with nutrition and in children. So these are very interesting paths for further exploration. But next one. Today, I don't think that there is enough evidence to consider certainly mono-nutritional therapy for Crohn's disease, but there certainly is hope for identifying responders and to counsel for healthy nutrition for prevention, for adjunctive therapy, and hopefully for maintenance of long-term remission. So the next one and the last slide shows you the waters of Venice. Unfortunately, I couldn't travel and we're all behind our screens due to COVID-19, but that has also some positive effects, such as the effect on the waters of Venice that became much more clear. And it was announced that swans and dolphins were returning to the waters. And that was a very romantic idea, but it wasn't true. So it just goes to show that some very appealing ideas, if you look closer, may not be true, but still the effect is very nice. I thank you very much for your attention.
Thank you, Gigi. Whoop. Am I on? Yeah, so Gigi, thank you very much. That was a wonderful overview of enteral feeding, enteral nutrition for inflammatory bowel disease, specifically Crohn's. I'll start with one quick question. You mentioned something about a phenotype that you might be able to predict responsiveness within 3 weeks, a recent study. Can you elaborate on that a little bit?
Well, the paper was published recently by Ariel Levine's group. They looked at the remitters, patients who went on to remission, and they looked at over time from when did they develop response. And the critical time appears to be 3 weeks. So if they improve, symptomatically improve, I'm not sure that they looked at calprotectin. They may have, but if you see improvement after 3 weeks, then you go on to remission. The ones who did not after 3 weeks would not. So it's a critical window.
So if they don't respond after 3 weeks, is that when they would add other immunosuppressive treatment?
I can't tell you exactly. Well, yes, no, of course. If they didn't respond, then they would get more. Yeah, I don't have the numbers, but that's what happens in practice. Yeah, they don't respond, and then you add immunosuppression.
And are they using any other types of diets with specific carbohydrate or anything else in Europe?
Very few. I mean, to tell you the truth, but that's individual cases. I mean, we don't have publications as you do. I personally have a few patients who wanted to do the specific carbohydrate diet by their own decision because they traveled to the US a lot and they were familiar with it. And of course, there are patients who do very well and who are able to stop their medication.
Yeah, whether it's the diet or placebo, we don't know yet because I think
Yeah.
that are all over the place. There are a couple of questions that are coming in now. One is from Dr. Becker. While there may not be adequate data to support monotherapy, could patients not be risk stratified based on disease severity for optional monotherapy as an initial trial?
Yes, I think that's a very good idea, especially also because it's difficult to propose diet to patients who are very, very sick and who are vomiting and who don't tolerate anything and who have very, very profuse diarrhea. Also, I mean, it was moderately active patients who were enrolled in the CDED trial had moderately active disease, not severe disease. I would also tend to think, because it's always a nice opportunity when you give a talk to think about, what are you telling people and how do we use it in practice and what would make sense. It seems more intuitive that it's less severe cases that we could treat this way.
I think that's been our approach. There is an interesting question about if you have somebody who has histologic active moderate disease, but it has no symptoms, and they decide not to use biologics or other immunosuppressive or treatments, could you get healing in these types of patients? Can you get mucosal healing using diet when they've got severe disease histologically?
Well, I mean, they're from the older studies with exclusive enteral nutrition, you can obtain mucosal healing. So if certainly the best patients to do these studies are the patients where the parents are absolutely adamant that they don't want immune suppression or they don't want biologics, and they are very motivated to adhere to these types of diet. So, and again, it's casuistics, but yes, I mean, I've seen such patients where they are so motivated and they want to avoid immune suppression, and knowing all the risks of immune suppression, I think many of us would do the same if it was our child who is ill. So the answer is yes. Yes, it's certainly worth trying.
How do you monitor the patient who's asymptomatic yet has endoscopic and histologic disease to make sure that they're having progression?
Well, you could certainly, I mean, they should certainly, if they have histologic disease, they must have abnormal calprotectin. So you can monitor them using calprotectin. But you're thinking of Crohn's really mostly then. Well, yes, of course, but I was thinking small intestinal Crohn's, small intestinal disease, yes.
Well, probably ileal or ileocecal disease.
Yeah, yeah.
So Phil Rosenthal read my mind because my next question was going to be, what's the role of fecal transplant? And he added also, what about sterilizing the gut with antibiotics? You can probably quote
Yeah.
study there too.
Well, antibiotics, as we know, has an effect, but mostly on colitis, be it Crohn's or UC. So it's also because it affects the microbiome, and same with fecal transplant. The results of fecal transplants in Crohn's are not very, I mean, conceptually, it would be a good idea, but I don't think that there's any good results that have been published, long-term results, especially in Crohn's. We also have had some short-term results in severe colitis, early onset IBD, but not long-term, not long-term.
I think one of the problems always is how do you give it? You know, do you give it by mouth or through a colonoscope, and how often do you give it, and how long do you have to keep giving it? And
Exactly.
Yeah.
Exactly how long you need to keep giving it, because the flora doesn't stay forever. So the patient will refer to his own fingerprints, so to speak. And antibiotics with diets, I think that's a very good idea. I don't know about any data. And not antibiotics, but probiotics, you know, was also, and that's in the same line as a fecal transplant. I think everybody was expecting probiotics to be very beneficial for Crohn's, and it couldn't be shown. There was a big study done by Colombel that was negative. So nutrition seems to have more of an effect than replacing the microbiota temporarily. But it's also on the long run, of course.
And there's the recent study from Europe, I guess, looking at azathioprine.
Azathioprine and nutrition.
And Flagyl. I don't know if nutrition was part of that, was it?
Well, there's a study, there's a Japanese study of also in adults, and that's anti-TNF and nutrition, and they also have a good result.
I mean, anti-TNF with or without nutrition, or nutrition with or without anti-TNF?
Anti-TNF with and without nutrition. Yeah.
Yeah. And then, well, there was also the one I was referring to was the study where they did azathioprine with or without, or I guess it was metronidazole with or without azathioprine. But they didn't have nutrition as part of that study.
No.
Or is there going to be, do you foresee any changes in the guidelines at this point, or do you think it's still preliminary?
I'm That's a very tricky question, because the guidelines will be published, so we'll see. I know there was a lot of discussion, but yeah, and that's also you know how motivated I'm also to change to healthy nutritional patterns and talk to patients about it. I don't think that now we have enough evidence to change the guidelines in a significant way. We would need a bit more evidence, and hopefully select patients. And the questions here go in that way: select specific patients that are not so ill. I also worry about undertreating patients, and the very ill patients really have difficulty tolerating any type of nutrition. So what do you do?
Yeah, you can't, you have to start with something else to get them quieted down. And we still avoid steroids, so we end up putting them on biologics at that point.
Yeah.
And I think with more and more biologics with pretty safe profiles they appear to have, it becomes an excellent option.
Yeah.
The problem we have is we need to keep them on that.
But also to come back to Dr. Zorila's question, you know, if a patient like that. The mother is a dentist, and so she wouldn't sleep at night because her daughter was on immune suppression on Imuran, and she thought, you know, that was really the worst. And she actually went on the specific carbohydrate diet. It's not easy to do it, but she keeps doing it. So she says that if she goes to a party and eats, you know, like ordinary food, which may be French fries or something like that, she feels it very quickly. So she really has to stay on that diet.
So there's another question about thoughts on the low incidence of Crohn's in the developing world that's now changing, and more with ulcerative colitis, and why there isn't more dietary interest with ulcerative colitis.
Well, there are the enteral nutrition studies have been done in Crohn's, because initially there was no result with ulcerative colitis, but some people think that you know, it was kind of given up, and maybe we should study it again. The only thing that I'm aware of is the link between red meat and ulcerative colitis. So we have less data because there is less interest, absolutely. So it's certainly a domain that should not be disregarded. I agree.
Do you see any role with nutrition or any studies that have been done looking at extraintestinal manifestations?
Good question. Not that I know of. Not that I know of.
It might be something interesting to look at, in particular with like PSC, which is very difficult.
Yeah, absolutely. Yeah, absolutely. Or even in rheumatoid arthritis. Yeah, no, that's a very good suggestion.
All right. Any final parting words? And then I'll turn it over to Dr. Hirsch.
Well, I thank you very much. And it's really an honor to be at UCSF Grand Rounds. I'm very motivated to work for patients with IBD, and I think it's important to remain critical and to have the excellent international collaboration that we have with the different societies. So thank you again.
Thank you. Maybe next year in person, right?
Yeah.
Hope so. Thank you so much, Dr. Veerman. We really appreciate you spending the hour with us. It was a wonderful presentation and discussion. Thanks everybody for participating, and I wish you a good rest of the week. Take care.
Thank you.
Bye, Gigi.